Distinguished guests, ladies and gentlemen, it's not often that I have my president as my warm-up act, but thank you to Michael for his words. Thanks also to Keshav Desiraju. It's been delightful to meet with him again. We've met on many occasions, and I've always enjoyed the stimulating debates and discussions with him. And as ever, I agree with so much of what he had to say, but I beg to disagree with him on some issues to do with family medicine training, as I will discuss during my presentation. I'm going to race through what WONCA is and what it does and what it can offer, just so that you're more aware of all the activities that are going on within this great organization. We're the World Organization of Family Doctors, but our funny name of WONCA comes from the original name of the organization, the World Organization of National Colleges, Academies and Academic Associations, etc., etc. As you can see, not a very user-friendly name, so that's why it's shortened to the World Organization of Family Doctors. But the acronym has stuck because it's got great brand recognition now, and we'd be very foolish to get rid of it. We're a big organization. We represent over 500,000 family doctors worldwide through 135 member organizations in all continents. We run through regions, and we have 7 regions. The regions is listed here, and of course India is in the South Asia region. Since our World Conference in Prague in 2013, every one of our 7 regions has had a young doctor movement, and that's been a real achievement. The young doctors, as we've seen over the last couple of days, are the future of our profession. We need to nurture them, we need to encourage them, and those of us who work with all of our young doctor movements are so encouraged to see how much they already contribute, how much energy and enthusiasm they've got, and it's wonderful that we can see that the future of family medicine is safe in their hands. Of course, the young doctor movement for South Asia is the spice route, and over the last couple of days we've heard much more about what the spice route is doing. And any of you who are young doctors and still qualify for membership, please get more involved in some of the spice route activities. WONCA organises lots of conferences. We've just had our WONCA Europe conference in Istanbul, and for the first time ever, we managed to get all 7 of our young doctor leads from all over the world, plus Raman as our young doctor representative on executive. We got them all together, and that was just a fantastic event, because in front of the whole audience, they were able to discuss some of the issues relating to young doctors and family medicine. We've got the South Asia Region Conference coming up in February in Sri Lanka, and I would strongly encourage you to come along to that. That'll be a fantastic program, and Shamali, who's the head of the scientific committee, is here at the conference, so please talk with her, and if you're interested in attending, get some abstracts in. We'll have another Europe conference next June in Copenhagen, but the big one, of course, is our next world event, which will be in Rio de Janeiro next November, and that promises to be the biggest and probably best WONCA World Conference ever, and we're anticipating about 6,000 delegates. WONCA publishes widely. This is of the WONCA Guidebook, The Contribution of Family Medicine to Improving Health Systems, produced with contributions from WHO. We also collaborated with WHO on integrating mental health into primary care. Our Rural Practice Working Party is extremely active, and they have produced this Rural Medical Education Guidebook, which I would strongly recommend to all of you. It's readily available and freely available and downloadable from the WONCA website. So any of you who are working in rural or isolated practices, please have a look at it. And we take environmental issues very seriously, and our Environment Working Party produced Family Doctors in the Field, environmental stories from across the globe. And early next year, our Research Working Party will also produce international perspectives on primary healthcare research, which I think will be a very useful publication. To summarise WONCA's key roles, the first thing is to bring the family doctors of the world together. The second thing is to support the highest standards of clinical care, education, training and research. And the third is to represent family medicine and general practice at the World Health Organization and at other major bodies. So let me go through some of that in a little bit more detail. Right. So bringing the family doctors of the world together. I've talked about conferences, but we've also got many working parties, special interest groups, the young doctor movement. Look at our website and have a look at the working parties and special interest groups because they cover a wide variety of specialties and disciplines. and almost certainly whatever your special interest is, it will be covered there. John Wynne-Jones, who's chair of the Rural Working Party, is present at the conference here. David Weller, who's chair of the Special Interest Group on Cancer and Palliative Care, is present here. So you have an opportunity to talk to some of these people and find out more about it. In terms of supporting the highest standards of clinical care and education, as always, we go back to the late, great Barbara Starfield, who's the nearest thing that family medicine has to a goddess, and we worship her regularly, because she is the one who produced so much of the evidence that we're able to use to persuade or to try to persuade policymakers about the clinical effectiveness and cost effectiveness of family medicine. And one of the things that she said was, health systems based on effective primary care with highly trained generalist physicians practicing in the community provide more cost-effective and clinically effective care. But please note the term highly trained generalist physician. And that's why Wonka has consistently emphasized and supported the concept of appropriate postgraduate training for family medicine general practice, and why we strongly support AFPI, which shares our goals and objectives. Now, Keshav has already talked about the challenges of training for family medicine. The aim of specialty training in family medicine is to prepare family doctors to provide long-term, person-focused, comprehensive, high-quality care for individuals, families, and communities. This requires training that's specifically designed to convey the knowledge, attitudes, and skills that are necessary for their future practice. However, family practice requires more than a series of disconnected training experiences. The family doctor has to learn to integrate and apply the knowledge and skills gained from other disciplines by providing comprehensive care to patients, families, and communities during their training. So why is family medicine education and training a little bit different? Well, in order to develop competency in providing high-quality primary care, as described by the World Health Organization, the family doctor needs to be educated in the core principles associated with such care. Wonka fully subscribes to the 8 core principles that guide family medicine education and research. First of all, access or first contact care. As family doctors, we're the entry point to the healthcare system, and we require a special set of skills that are somewhat distinct from those of other providers. In this setting, patients present with a wide variety of medical problems and degrees of severity, and no other medical specialty faces such an extensive range of undifferentiated health problems. We have to be expert at determining who is well and who is sick, managing a wide range of problems and severity, and identifying those in need of more advanced subspecialist care. And note, I prefer to use the word subspecialist. I don't believe they are super specialists. I believe they're subspecialists. Secondly, comprehensiveness. As I've already said, because of the undifferentiated nature of many problems and the need to see all the people who present for care at the grassroots level, the family doctor must be prepared to deal with a wide variety of patients and illnesses and should be armed with a comprehensive set of clinical skills. So the family doctor needs to be able to care for patients of all ages, genders, and cultures, or cradle to the grave, as we would say. They need to be able to diagnose and manage a wide range of illnesses, not limited by organ systems, to be able to recognize and be familiar with all local common diseases, to provide emergency services and surgical interventions consistent with their training, local need, and available resources. And I always cite the Nepal experience because the family doctors there do a 4-year intensive family medicine residency program, which includes emergency obstetrics and emergency surgery, because when they're posted out to district hospital level, they're the only people available with those skills, and that's really, really important in terms of the services that they offer. We need to promote family planning, and of course we need to be involved in preventive and health education services. And another great doyen of family medicine was the late Professor Ian McQuinney of Canada. And he nicely encapsulated all of this when he said, the family doctor is committed to the person rather than to a particular body of knowledge, group of diseases, or special technique. We deal with continuity of care because in most other medical disciplines, patients are seen for a disease-based complaint, and a healthcare provider only follows them on visits related to that complaint. In the case of family medicine, the family doctor seeks to establish a long-term relationship with each person rather than simply focusing on a disease. Another concept is coordination. There's a real need for one key person to look after the overall interest of the patient and to adopt a more generalist point of view, and that person has to be the family doctor. This is especially important as medicine goes along the specialization and subspecialization line. That's not necessarily a bad thing, but with that and with greater and greater comorbidities among our patients, there is the need for this one key person to coordinate things and to act as the patient's advocate. We need to be skilled in prevention, not just in primary, secondary, and tertiary prevention, but we now need to add in quaternary prevention, identifying the risks of over-medicalization and protecting a patient from additional or inappropriate medical invasions or interventions that are ethically unacceptable. We need to be family-oriented. We must learn to routinely consider patients in the context of their families and apply a family approach to patient care. This begins with understanding the role of families in health and illness behaviour, the dynamics of family systems and stages of the family life cycle. And we also need to be community-oriented, because where our patients live, how they live, where they work and what they work at, all these factors influence the context in which the patient presents. So we need to look after the patient in the context not just of the home, but also the workplace, where illness may be generated or aggravated. And Keshav referred to the concept of person-centeredness. And perhaps the most fundamental difference between family medicine and other medical disciplines is the overriding and core guiding principle of person-centeredness. This shifts the focus of clinical care from a curative, disease-based approach to health to a more holistic and collaborative focus on the health of the entire person. Of course, this principle of person-focused care should be core to all fields of medicine, but family medicine most especially takes on the principle as the driving force behind how all healthcare should be delivered. But the idea of person-centeredness, of course, is not new, because this man, Hippocrates, over 2,000 years ago said, it's more important to know what sort of person has a disease than to know what sort of disease a person has. In other words, we need to listen to our patients and respond to their needs and their agenda. Now, to help to drive this training in the core principles, Wonka has devised global standards for all postgraduate family medicine education programs, which can assist those who want to develop or improve their family medicine training program. Many now use them as a useful guide, but Wonka can also offer formal accreditation to any program that applies for a formal assessment against the Wonka criteria. The first program to be accredited under the new system was Shanghai Medical College of Fudan University in Shanghai, and this photograph shows Professor Zhu of Shanghai Medical College receiving the certificate of accreditation from our president, Professor Michael Kidd, watched over by Dr. Margaret Chan, Director General of WHO. But how do we attract students to family medicine in the first place? This training for and exposure to family medicine shouldn't just start at a postgraduate level, and it's vital that we introduce our undergraduates to family medicine at an early stage in their studies so that they can appreciate that this is a viable career option. When students interact with family doctors in classroom and clinical settings and see family doctors as valued members of health teams, they're more likely to consider a career in family practice. In Keshav talked about the mismatch between the numbers of doctors and where they're practicing. And this slide shows a number of strategies which can be used to attract students to careers in family medicine. First of all, we can recruit and admit students to medical school who are interested in primary care and community service. And around the world, there's a network of community-oriented medical schools who are actually working really, really hard at this. They recruit people from rural communities to go to the medical schools, and when they qualify, the majority of those people return back to the rural communities to be able to provide health services. That's a really important initiative. We need to emphasize primary care in the curriculum, and we need to expose students to family medicine role models. We need to provide specialty or focused training options within family medicine training. So in other words, although we have more generalist training, you might do additional training in obs and gynae or cardiology or whatever. We need to provide incentives to encourage selection of careers. We need to offer a variety of career opportunities. And perhaps most important of all, we need to support family medicine graduates with competitive salaries after training. Now, Wonka's recognized this for some time, and in 2007 it formulated the Singapore Statement to emphasize the need for medical students to be exposed to family medicine during their undergraduate time in order to expose them to this future career option. And it said that every medical school in the world should have an academic department of family medicine, and every medical student in the world should experience family medicine as early as possible and as often as possible in their training. And that's a really important statement, I think. I mentioned our work with WHO. And this is the third strand of our activities, and one which our member organisations value enormously. We've established ever closer cooperation with WHO in a whole range of areas, and this only touches on a small part of some of the activities that we're closely involved with WHO in. We meet regularly with WHO colleagues, especially during the WHO Executive Board in January and the World Health Assembly in May. And I myself was in Geneva a couple of weeks ago, attending a meeting on cardiovascular disease and one on ageing and health. And increasingly, our regional presidents are attending the regional council meetings of WHO. Professor Pratap Prasad, who's the South Asia regional president, regularly attends the CRO WHO regional meetings. The world needs family medicine. The Sustainable Development Goals will drive government policies in many countries of the world for the next 15 years. There is only one health goal, Goal 3, but many of the other SDGs relate directly to social determinants of health, and so are of obvious interest to us. Number 5 is on gender equality, for example. Number 6 on clean water and sanitation. Number 13 on protecting the planet. So these are all directly impacting on health. One of the targets within Goal 3 is universal health coverage, and I think the next session has a session on universal health coverage. If countries of the world are going to provide universal health coverage to their citizens and provide the long-term, person-focused, comprehensive, high-quality care for individuals, families and communities that I talked about at the beginning, then a basic MBBS doctor is not enough. Only a family doctor, properly trained, can offer the compassion and accessibility, the continuity and coordination, and the comprehensiveness and holistic and family-centred approach so desperately needed. But don't just take my word for it. I showed a slide of Dr. Margaret Chan in Shanghai, and she's a huge supporter of family medicine and of Wonka. She gave the keynote address at our World Conference in Prague in June 2013, when she said, "A health system where primary care is the backbone and family doctors are the bedrock delivers the best outcomes at the lowest cost and with the greatest user satisfaction." And I was at a meeting later that year at the Hong Kong Academy of Medicine, and in front of specialists from all 15 specialties recognized in Hong Kong, she said, "Let me be clear, I love family medicine," which was music to our ears, but not so much to the other 14 specialists who were present. So that is Wonka, working hard to promote family medicine globally, to drive up training and health delivery standards, and to be the voice of family medicine with the major global players. Come and join us in our great journey ahead. Get more involved in Spice Route, or our working parties, or our special interest groups. Chat to me, or Professor Ruth Wilson, our North America president, is here, or John Wynne Jones, or David Weller. Amanda Howe, our president-elect, will be joining us later on this morning. You are all most welcome in the Wonka family. Thank you.